Dr. Kenya Barnes pushed through the swinging doors of Cedar Valley Medical Center's surgical wing just before 6:30 a.m., her white coat flapping behind her like a banner of purpose. The corridors glowed under antiseptic fluorescence, their linoleum floors polished to a sterile shine. After 15 years on the cardiothoracic team, Kenya had lost count of the number of heart-lung machines she'd calibrated or the precision with which she'd threaded sutures through delicate vascular grafts. Yet this morning, as she approached the staff locker room, the code on her ID badge elicited only a cold red flash. She swiped again. Red. She tapped the keypad. Nothing. Heart pounding, she glanced left and right along the empty hallway and pressed her palm to the sensor. Still nothing. Behind the reinforced glass of the scrub room's pass-through window, the head nurse, Carol Matthews, hovered over a neatly folded stack of charcoal gray scrubs, each set marked with the embroidered CVMC crest. Carol's eyes flicked to the badge reader, then back to Kenya, her lips forming a practiced, apologetic smile. Dr. Barnes, she called through the small hatch, voice clipped. There's a problem with your credentials. They've been deactivated for today. Kenya's breath hitched. Excuse me? She half stepped into the doorframe. I have a 7-hour block in the OR. Is this about that meeting yesterday? Carol raised a hand. I'm sorry, doctor. The administration noticed you raising concerns about case assignments and trauma review. You'll need to see human resources before accessing any restricted areas. She turned away, folding her hands, as if the matter were closed. Kenya's heart thundered, not from the dawn's usual pre-op adrenaline, but from the cold shock of exclusion. She produced a printout of her schedule. 7 a.m. to 3 p.m. Aortic valve replacement, OR3. She pressed it against the glass. This is my day's work. Carol's shoulders rose. I understand, but without authorization, I can't issue you scrubs. You'll have to wait for HR. She slid the hatch closed, sealing Kenya out in the sterile hallway. The lock clicked behind her like a verdict. Moments later, Kenya's pager erupted with the urgent cadence of a code blue ICU room 12. Across the hall, she glimpsed the outer doors of the critical care unit swinging open as custodial staff and an aide rushed past. A patient's life hung in the balance, and the lead ICU nurse barked into a phone, "We need the cardiothoracic team now." Kenya lunged toward the nurse's station. "I need scrubs," she yelled, voice echoing off the corridor's tiles. "There's a patient crashing." But Carol was already buttoning the hatch shut. A security door glided down at the end of the hall, barring her path. Kenya's heart clenched, not from the impending emergency, but from the barrier that stood between her and her calling. As the code blue team sprinted past, Kenya pressed her hand to the locked hatch, her knuckles white. Every second felt stretched into an eternity as she realized that the uniform barrier meant more than lost minutes. It threatened a life. With her mind racing, Kenya stepped back, her surgical cap clenched in one fist. She would not stand idle. Lives depended on her skill, and she refused to let a locked door define her worth. Already her boots echoed a new resolve as she scanned the corridor for a way in, knowing that to save a heart, she might first have to break through the walls that tried to keep her out. Dr. Kenya Barnes tore down the sterile hallway, her coattails snapping like a banner of defiance against the bright overhead lights. Behind her, the muted alarm of the code blue echoed down the corridors, a frantic Morse code of crisis. She rounded the corner toward ICU room 12, where the monitors and ventilators converged in a symphony of beeps and hiss. Peering through the glass, she saw the patient, Mr. Caldwell, a 52-year-old with a ruptured aortic aneurysm, his chest heaving under blue surgical drapes as ICU nurses fanned his face with oxygen masks. The lead nurse, Marcus Lee, turned at Kenya's knock on the window. "We've tried everything," he said through gritted teeth. "His blood pressure is tanking. No surgeon is allowed in." Kenya's jaw clenched. "Then we'll get you one," she snapped, eyes flicking to the locked inner door, where a security badge reader glowed red. "HR is on their way," Marcus warned. "You'll have to wait." She pressed her palm to the glass, heart thunderous. "He's bleeding out. I can stop it." A chorus of monitor alarms cried out as Mr. Caldwell's pressure plummeted. A nurse shouted, Prep the defibrillator! But Kenya shook her head. Not yet. He needs chest exploration and direct aortic control. Now. Behind the ICU nursing station, a janitor wheeled a cart laden with linens and biohazard bags. Kenya intercepted him. Jose, I need your master key. He hesitated, eyes flicking to the locked door and then back to her surgeon's badge. They told me not to, he mumbled. But I can't watch him die. With trembling hands, Jose unlocked the door's inner latch. It burst open under Kenya's push. She crossed into the ICU bay, scrubs trailing behind her like a crusader's cloak. Marcus snapped a pair of sterile gloves onto her hands and handed her a folded gown. Kenya fastened it with purpose, shedding her coat to reveal her scrubs beneath, the uniform of her profession and her promise. Nurses cleared a path as she climbed onto the bed platform. The patient's arterial line had gone flat. His carotid pulse was vanishing. Kenya placed 2 fingers on his neck. He's slipping, she said, voice calm steel. She scanned the team. I need a portable cautery unit, a Heineken retractor, and the crash cart's heparin flush. Hands moved in choreographed urgency, and Kenya's eyes never left the patient. With gloved precision, she made a 6-inch incision above Mr. Caldwell's sternum, peeling back tissue layers to expose the pericardium. Blood welled beneath her fingertips. The ICU ceiling's fluorescent grid vanished as she focused on the scarlet field before her. Blood spurted from the ascending aorta, a catastrophic tear. A nurse pressed a fingertip to stem the flow, while Kenya commanded, "Clamp the proximal aorta! Hand me the Satinsky clamp!" In one fluid movement, she controlled the hemorrhage, then reached into her gown pocket for a heparin syringe. She injected the line and deftly sutured the intimal tear with 4-0-proline, each stitch a lifeline. The room held a collective breath as she withdrew the clamp. The bleeding slowed to a dark ooze, then stopped. The ventilator's hiss steadied, and the patient's systolic pressure climbed from 40 to 80, then settled at 100. Nurses exchanged relieved exhalations. As Kenya finished closing the wound, HR personnel arrived, 2 administrators in crisp suits, faces flushed with apologies. The lead administrator stammered, "Dr. Barnes, I'm so sorry you were..." Kenya set down her scalpel and met his gaze. "He almost died waiting for them," she said quietly. "Lives can't wait for bureaucratic clearance." She straightened, blue gown stained with red testament to her intervention. "My only credentials that matter right now are these hands." In the hushed aftermath, as Mr. Caldwell was transferred back to full OR care, Kenya stepped out into the hallway, scrub cap askew and badge still active by the ICU door she'd forced open. Her resolve had been vindicated, her skill undeniable. But as the echoes of monitors faded, she knew her fight had only begun. No surgeon, no matter how skilled, should ever again find herself locked out when a life hangs in the balance. The morning after the code blue rescue, Dr. Kenya Barnes sat in the cold, glass-walled conference room of Human Resources, flanked by 2 hospital lawyers and the chief operating officer, Thomas Avery. His crisp suit immaculate, but his eyes troubled. Behind them, the scrub room's locked door gleamed, a silent witness to the storm that had erupted. Avery cleared his throat. "Dr. Barnes, we appreciate your skill and that you saved Mr. Caldwell's life. However, your bypass of protocol and unauthorized access to the scrub room cannot go unaddressed." His polished tone failed to mask the subtext. Rules were rules, even when they endangered patients. Kenya folded her arms, each breath steady with conviction. Protocol is a safeguard, not a shackle. When every second counted, that door nearly killed him. "I'll answer for my actions, but only if you answer for yours." The lead attorney, Marissa Cole, tapped a stack of documents. "Here are your personnel records. Notably, you filed several formal complaints about discriminatory case assignments." Kenya's gaze sharpened. "Yes, I've logged patterns where my patients were reassigned without cause, and where surgeons with less experience were favored over me. I complained in good faith. Yet when I pressed for accountability, you deactivated my credentials." Avery shifted uncomfortably. "Those concerns are under review. We need to maintain order during that process." "But order nearly suffocated a man's life." Kenya leaned forward. I want three things. First, a written policy guaranteeing any credentialed surgeon unrestricted access to scrubs and ORs in an emergency. Second, a bias interruption training program for all staff, led by independent experts. Third, a formal acknowledgement that protocol must never override patient care. Cole glanced at Avery, whose jaw tightened. That's ambitious, she said. We can't promise immediate implementation of all demands. Kenya's voice turned quiet steel. Ambition is what drives breakthroughs in the OR. Aorta can't wait while you negotiate timelines. She laid her hand flat on the table. Lives depend on your decision now. Avery closed his eyes briefly, then opened them with resolve. All right, we will draft the emergency access policy by week's end and convene a mandatory training session within 30 days. As for your complaints, we'll expedite the review with an external ombudsperson. Kenya exhaled. And an apology to every patient who's lost precious minutes while policies took precedence over care. Silence filled the room before Avery nodded. You'll have it. As Kenya rose, the doors to the scrub room behind her unlocked with an audible click. She did not turn to look. Her victory was not in a door's mechanism, but in the promise that no caregiver would again be locked out when a life hung in the balance. And with that assurance, she strode toward the OR, her resolve tempered by the knowledge that true change often demands confronting every barrier, no matter how sterile or reinforced. Dr. Barnes strode into the cath lab before sunrise, the soft hum of the imaging equipment greeting her like an old ally. She had insisted on taking the weekend on-call shift, knowing that emergencies didn't pause for bureaucracy. As the lead interventional cardiologist, she reviewed Mr. Caldwell's angiogram films from last night's emergency repair, images she sent with her midnight petition to HR, and then turned her attention to the new consult. A 58-year-old woman in cardiogenic shock, en route by ambulance from the community hospital 40 miles north. Within minutes, the trauma team had transferred the patient onto the sleek procedure table. Monitors flashed alarming numbers, a collapsing blood pressure, tachycardia that seemed to set the very room trembling. Nurses called out values as Kenya's gloved hands danced across the prepped groin site, securing a 6 French sheath into the femoral artery. She guided the catheter toward the heart under fluoroscopy, her eyes sharp behind her visor. The contrast dye bloomed on the screen like an inky river, revealing a near-total occlusion of the left main coronary artery. This isn't a simple stent, Kenya said, voice calm but urgent. She needs a cutting-edge bioresorbable scaffold, and quick. The techs hesitated. Protocol dictated that only the OR could schedule advanced devices, and only with 3 levels of administrative sign-off. Without her credentials, those signatures might not arrive in time. Yet, with the patient's heart teetering on the brink, there was no choice. Kenya reached into her personal kit, a compact bag she'd packed in defiance of standard-issue rules, and pulled out the scaffold. She bypassed the usual pharmacy check, whispering to the charge nurse, "We'll document everything. Right now, I'm her lifeline." The team, galvanized by her certainty, readied the delivery system. She navigated the guide wire across the lesion like threading a needle, then advanced the scaffold with millimeter precision. As the balloon inflated, the vessel walls splayed open, sunlight bursting through dark clouds. Contrast surged downstream, and the monitor's pressure waveform climbed, systolic rising from a perilous 60 to a healthier 100. The cath lab erupted in quiet exclamations. "Nice work, Doc." But the crisis wasn't over. A sudden arrhythmia flickered on the EKG, the patient's heart slipping into ventricular tachycardia. Kenya barked orders, "Give me 500 micrograms of amiodarone and prepare the external defibrillator." A nurse injected the drug as Kenya placed paddles on the patient's chest, her hands steady on the handles as she waited for the surge of energy to restore rhythm. When the shock delivered, the EKG straightened into a steady sinus wave. Relief rippled through the lab. Later, as the patient stabilized under ICU transfer protocols, Kenya documented every deviation from procedure, every extraordinary measure taken to save a life. She knew the hospital's leadership would scrutinize her file, But she also knew that without her defiance of locked-door policy and restrictive credentialing, the woman before her would be dead. Exhausted but triumphant, Kenya exited the cath lab to find the door to the scrub room unlocked for her again. In the overhead lights, she saw reflected not just her own fatigue, but the glow of vindication. Patient care would always trump policy, and no sterile barrier could hold back a surgeon's commitment to life. The following Tuesday, the hospital's morning calm shattered with the urgent summons of emergency heart code, a rare alert reserved for the most critical cardiac crises. Dr. Kenya Barnes, fresh from a night of chart reviews and mentorship with the cardiology fellows, raced toward Operating Room 5, where anesthesiologists and perfusionists were already assembling the heart-lung bypass machine. Inside the OR, the patient, Mr. Delaney, a 60-year-old construction foreman, lay supine with a sternotomy incision, recalling last night's triumphant cath lab rescue. His vitals had stabilized until an acute posterior myocardial infarction crashed in like a rogue wave. The monitors bled red with alarming arrhythmias and plummeting pressures. Nurses whispered about how fast this had happened. One moment he was recovering in ICU, the next he'd flatlined en route to the cath lab. Kenya scrubbed in under the bright surgical lights, her eyes meeting those of her veteran scrub tech, Maria. Without a word, they fell into practiced choreography, retractors locked into position, suction lines primed, and the bypass circuit's tubing flushed and ready. Kenya's heart pounded, not with fear, but with the singular focus honed by years of crisis management. "Scalpel," she said, voice steady. Maria handed it over without hesitation. Kenya reopened the mediastinum, the residue of chest tubes and surgical glue giving way to the raw vulnerability of the heart's exposed apex. A frantic glance at the rhythm strip confirmed ventricular fibrillation. The anesthesiologist called for internal paddles. Kenya took them in hand, placing the paddles directly on the ventricular walls, and delivered a synchronized shock. The monitors flickered, then steadied into a slower, tenuous sinus rhythm. But the damage from the new infarct demanded more than defibrillation. It demanded immediate surgical revascularization. Kenya's eyes locked on the posterior descending artery, now ominously constricted by clot. She secured a segment of the patient's saphenous vein, fashioning it into a bypass graft. With microsurgical precision, she anastomosed the vein graft to the aorta and then to the occluded artery's healthy segment, her sutures drawing the graft snug against pulsating tissue. Throughout, she barked succinct orders. Clamp proximally, heparinize the graft, release clamp. Let's see flow. As the clamps dropped, fresh arterial blood surged through the graft in a bright, life-affirming rush. The perfusionist nodded. Adequate flow confirmed. Kenya closed her eyes for a heartbeat, allowing the gravity of that single moment to take root. An infusion of redemption, not just for Mr. Delaney's heart, but for her own embattled role in the hospital. By the time Mr. Delaney was wheeled back to ICU, his chest closed and heart beating strong, Kenya stepped out into the corridor, sweat dampening her hairline beneath her scrub cap. There, the head nurse and the HR director waited, their expressions unreadable. Kenya met their gaze steadily. "He almost died waiting for bureaucracy," she said softly. "But we saved him, because we refused to wait." As they unlocked the scrub room's door for her, again, the echoing click sounded less like permission and more like promise. That no matter how fierce the code, no matter how rigid the protocol, her skill and resolve would always break through the barriers between surgeon and patient, ensuring every heartbeat had the chance to continue its story. Word of Dr. Kenya Barnes' daring bypass during the emergency heart code rippled through Cedar Valley Medical Center like a shockwave. Hallway whispers turned to proud nods, and surgeons from every specialty paused mid-procedure to congratulate her, though the scrub room door had only just reopened for her. But Kenya knew that true redemption lay not in accolades, but in ensuring no colleague would ever face the same barriers she'd shattered. 2 days later, the hospital convened an all-staff meeting in the Grand Conference Auditorium, a rare occurrence reserved for the most urgent institutional matters. The CEO, Dr. Margaret Cho, took the podium beneath a banner reading, Patient care above all. Behind her, a projection displayed two stark images side by side, the locked scrub room door and the triumphant shot of Kenya, gown streaked with surgical blood, standing beside Mr. Delaney's stabilized monitors. Dr. Barnes saved 2 lives in less than 1 week, Cho announced, voice resonant in the hushed room. Her actions exemplify our mission, yet she was forced to circumvent our own protocols to do so. That ends today. A ripple of applause rose, but Kenya held her breath, knowing the depth of change required extended beyond applause. Cho continued, effective immediately, we are enacting the following reforms. Universal Emergency Access Policy. Any credentialed clinician, surgeon, specialist, or fellow will have immediate, unrestricted access to all scrub rooms and operating theaters upon activation of any cardiac or trauma code alert. No badge deactivation, no override delays. Bias interruption training. Mandatory, immersive workshops for all clinical and administrative staff, led by external experts in healthcare equity. These sessions will feature real-world scenarios, including locked-door emergencies, and teach stop-step support interventions to uphold care above all else. Patient-first ombudsperson. Appointing an independent officer with the authority to investigate any policy that impedes patient care, report directly to the board, and enforce corrective action within 48 hours. As each bullet point appeared on the screen, Chelsea Park, the nursing director, rose to her feet. These reforms will save lives, yes, she said, voice catching with emotion, but they will also restore trust among our staff and between us and every patient we serve. Kenya watched as over 100 physicians, nurses, techs, and administrators rose in applause, a standing ovation that filled the room. Yet her mind turned to the countless patients who might not survive locked doors or delayed interventions. It was for them that the reforms mattered most. In the days that followed, Kenya spearheaded the first bias interruption workshop, drawing on her own experiences. She led role-play exercises, locked door simulations, interdepartmental code drills, and debrief sessions, analyzing the emotional toll of near misses. Attendees, a mix of seasoned surgeons and junior residents, shared candid reflections on times they'd hesitated or witnessed colleagues hesitate when care demanded immediate action. Meanwhile, the patient-first ombudsperson, Dr. Ravi Menon, opened the first investigation into the locked door incident. HR records were audited, and within 72 hours, formal apologies were issued to Kenya, Mr. Caldwell, and every clinician affected by credential deactivations. The hospital's digital dashboards now displayed real-time compliance rates for emergency access, visible to all staff via the intranet. As weeks turned to months, the policies hardened into practice. The scrub room badges were reprogrammed to default to open mode during any code alert. Bias interruption modules were built into annual certifications, and Dr. Barnes, once excluded, now chaired the Patient Safety Council. Each meeting began with a roundtable reviewing code events, celebrations of swift coordinated care, and candid analyses of any friction points. One early morning, as Kenya passed through the scrub room, badge beeping green, she paused to watch a group of third-year residents logging in for a trauma drill. Their faces reflected determination, not dread, and their footsteps carried the confidence of clinicians unshackled from needless barriers. Later, in the quiet of her office, Kenya reflected on her journey from locked-out surgeon to systemic reformer. She opened a file marked Patient Care Protocols, a document she'd drafted late nights, weaving together lessons from near misses, best practices from peer institutions, and the guiding ethic that had always driven her: lives first, always. As she saved the final revision and shut down her computer, Kenya knew that while surgical skill had saved Mr. Caldwell and Ms. Delaney, the true triumph lay in salvaging a culture of care, transforming Cedar Valley from a place of potential barriers into a sanctuary where every heartbeat mattered and every clinician stood ready to answer its call. 1 year after the scramble to unlock that scrub room door, Cedar Valley Medical Center stood transformed into a beacon of patient-first care. Dr. Kenya Barnes now chaired the newly established Patient Safety and Access Committee, meeting every month in a glass-walled conference room overlooking the ICU courtyard. The walls were lined with framed commendations, one for every life she'd saved in breach of protocol. But Kenya regarded them as milestones on a far longer journey. Today's agenda was ambitious, extending Cedar Valley's universal emergency access policy across the entire state health system, integrating bias interruption training into every medical school's curriculum, and launching a code-unlocked fellowship for young surgeons committed to dismantling barriers. As she reviewed the proposals, representatives from the Department of Health, the State Medical Board, and the Nurses Association filtered into the room. Kenya opened the meeting with a slideshow chronicling the past year's data: a 98% reduction in delayed care incidents during Code Blues, complete compliance with the new override panels, and more than 5,000 staff trained in stop-step support interventions. She paused on a photo of ICU Room 12, its monitors now cool and silent, captioned, "Where protocol failed, humanity prevailed." "Colleagues," she began, voice steady, "we turned a single locked door into a statewide movement. But our work is not done. We must ensure that no surgeon, no nurse, no EMT ever again faces a barrier that jeopardizes a life." She clicked to the first proposal: Statewide Emergency Access Compact, a binding agreement among all public and private hospitals to adopt Cedar Valley's policies verbatim, enforced by quarterly audits from the Health Department. Dr. Elena Park, Deputy Health Commissioner, leaned forward. "The compact's language is clear and enforceable," she said. "Our legal team has vetted it, and we can publish it within 2 weeks for legislative ratification." A ripple of approval swept the room. Next, Kenya introduced the Bias Interruption in Medical Education Initiative. Partnering with the State University School of Medicine, she'd co-developed a semester-long module combining virtual reality simulations of locked-door emergencies, compassion training workshops, and reflective narratives from clinicians of diverse backgrounds. She displayed a video testimonial from a third-year resident. "Before this training, I didn't realize how unconscious bias could cost a life. Now, I'll intervene every time." The dean of the medical school, Dr. Samuel Ihara, nodded vigorously. "We'll launch the pilot this fall and aim for full integration by next year." Finally, Kenya unveiled the Code Unlocked Fellowship, a competitive program sending early career surgeons and nurses to underserved rural hospitals. Fellows would oversee the installation of override panels, conduct bias workshops, and mentor local staff, returning with case studies to refine statewide policy. She flicked to a map dotted with prospective sites, from mountain clinics to coastal community hospitals, each representing another community once at risk from locked doors. As the meeting drew to a close, Kenya reflected on the arc she'd helped shape. From the indignity of exclusion in the scrub room doorway, to the adrenaline of ICU rescues, the courtroom of public opinion, and the boardroom of institutional reform. Each step had demanded not just surgical precision, but moral courage. Scrubs and scalpels wielded in service of systemic change. Later, alone in the quiet of the committee room, Kenya reviewed her personal notes. Stories of patients who'd survived because protocols bent to necessity, of colleagues who'd embraced the new culture of intervention, and of trainees who now wore their badges with renewed pride. She closed her notebook and rose, the late afternoon sun streaming through the glass, illuminating the corridor outside, where staff passed freely, each one a living testament to barriers broken and care unbound. Stepping into the hallway, Kenya paused by the scrub room door, its badge reader glowing green without a second thought. She pressed her palm to the sensor, then slid inside, running her hand over the neatly folded gowns as if greeting old friends. In that simple act, she honored every surgeon, nurse, and patient whose life had depended on this door opening. And as she donned her scrubs for the evening round, Kenya carried with her the quiet knowledge that true healing extended beyond stitches and sutures. It resided in every policy rewritten, every bias interrupted, and every door kept open for the next heartbeat in need of saving. Sprosit ChatGPT